So the objectives for our time together today is to discuss the management of menopausal symptoms and particularly sexual health considerations during that time period for women with diabetes. So we're going to go through an introduction. We're then going to spend some time having a didactic lecture, including some case studies. And then there'll be time for questions and answers. If you want to enter questions into the question queue as we go along, you're welcome to do that. However, I probably won't be able to see them until I go looking for them at the end. And then we're going to sum things up and close. So by way of background, diabetes is a growing epidemic in this country. It has kept pace with our obesity epidemic. It's now estimated that there are almost 29 million people above the age of 20 who have diabetes, and that reflects 12% of the population over 20 years of age. But when we drill down further and we look at the age breakdown, we see that this is very much of a disease of the older population. While women between the ages of 20 and 44, about 4% of them have been diagnosed with diabetes. When we get to these perimenopausal years, the numbers are about 16%, and in those 65 and older, it's almost 26% of the population. So timing of menopause causes a bunch of changes in a woman's body, and one of the things we have to be mindful of is that that may affect her body's ability to manage sugar, and if she was on the borderline diabetic stage before menopause, she may be tipping over, and so we need to watch that carefully. And of course, any lifestyle changes in terms of diet and exercise and trying to control her weight and particularly her waistline, because we know that visceral adiposity is most likely to result in diabetes, is going to be very helpful. So diabetes, menopause overlap in causing risk of cardiovascular disease, and so it's important to address both of those as risk factors that may be things that we can address in our hopes to decrease women's risk of going on to develop heart attacks or strokes. So the first question for you is, which of the following are components of high-quality counseling for postmenopausal, or I would say even perimenopausal women with diabetes? And so we have a quick poll that is open that will let you select whether you think tailoring the counseling to women's needs and preferences, supporting, achieving, and maintaining healthy weight, discussing use of aspirin and a statin, assessing risk of sexually transmitted infections, or all of the above. And Caitlin, I think, is in charge here, and will hand back control in a minute. And hopefully even be able to share with us the results of that poll. And we see that the large majority of folks felt that the answer should be really all of the above. And I would say, I think that's the right answer, which means that those of you who chose something else didn't answer it wrong. You just didn't read all the way to the end of the question. So of course, in any clinical care, assessing what the woman's needs are and what her preferences for care are going to be really important. During this time in her life, providing support for attaining and maintaining healthy weight is really important. And the message that physical activity is important, even if her weight does not change, is another really important one to be sharing with our communities, because it's that physical activity that's going to make sure that their heart is able to function in the stresses that it's facing. The other thing that we need to think about is the medications that have been widely studied and found to be highly effective in reducing risk of cardiovascular disease, and so those are going to be the statins and aspirin. Simple over-the-counter baby aspirin, 81 milligrams a day. Sometimes contraindicated, but very rarely so, and really almost all women by the time they hit age 45 should be taking an aspirin a day unless they have some reason why they're not able to tolerate that. And unfortunately, even though it gets very high endorsement from evidence review groups like the U.S. Preventative Services Task Force, it's one of those easy and over-the-counter things that we often forget to discuss with women. The other thing that's important to revisit is women's perceptions of their risk of sexually transmitted infections as women's lifestyle changes and concerns of pregnancy decrease. Sometimes women's concern about sexually transmitted infection risk may go up, and so screening may be needed. The other thing that can happen when women enter the perimenopausal period, which can last for up to 10 years, so can be a very long period of a woman's life, can be symptoms around vaginal dryness as well as painful sex or dyspareunia. So these are topics that are sometimes hard for our patients to raise with us, and we want to make sure that we're giving them a clinical environment where both they feel comfortable discussing these things and we provide prompts that open conversations where it makes it clear that we're happy to discuss these issues. So asking about discomfort with sex, use of lubrication, and whether or not their symptoms are resolving with those efforts. Often helpful to reassure women that changes in the vaginal mucosa are common during this perimenopausal period, as not all women have been able to discuss this with family members, and this wasn't part of the sex ed that most people got back in high school. Our treatment for these symptoms, first line treatment, is vaginal lubrication. If women are smoking, encouraging them to quit smoking is going to be important for all sorts of reasons in terms of trying to promote their cardiovascular health, but it can also be a effort that can be helpful in trying to resolve some of these vaginal symptoms, and sometimes that can be sort of an additional incentive that can help people think about the ways that they can try to address that lifestyle habit that can be so addictive and so difficult for people to break free of. Second line treatments would be low-dose estrogen applied to the vaginal mucosa. The lowest formulation available is the product that is a ring that is called Estring, E-S-T-R-I-N-G. And so that's where I usually start, though there are many other options, and there's no real right answer about which estrogen is going to be best for any given woman. Osphenifene is another product that has been brought to market. It's a selective estrogen receptor modulator and is also an option, though in my mind not one that's necessarily advantageous over the older estrogen products. So asking about sexual dysfunction is also important because this is an important part of women's lives. We want to ask about specific symptoms, whether these seem to be related to any medications or changes in their relationship or interpersonal factors. If there's underlying depression, that is often an important thing to treat, but we also have to be mindful that the SSRIs, which are often used to treat depression, may affect sexual function, and if the symptoms seem linked to use of a SSRI medication, considering dose reduction or proprion can be helpful in addressing that. Relationships is always important about this, perhaps most with our younger women and perhaps a little bit more prevalent in that age range, but unfortunately doesn't go away altogether as women get older and wiser, and is something we still need to be trying to support women around. And then sometimes for women who've had pelvic floor trauma, childbirth, pelvic floor physical therapy can also be helpful. Trying to advance the slide here, but seem to be having a little bit of technical difficulty. There we go. So the other news, oops, and now it advanced too much. The other news over the last year has been this FDA approval of a medication called ADI, or flubanserin. And I just wanted to be clear that though there was a lot of news around that, that was approved for premenopausal women, not postmenopausal women, and probably not a good option for our patients who have diabetes. But just to be clear on what that one is, it's the first treatment for female sexual desire disorder labeled as such. It's a serotonin 1A receptor agonist and a serotonin 2A. That being said, there is not a clear understood mechanism on how those serotonin receptors or improve sexual desire or reduce. The medication carries big warnings that it is not to be used with alcohol or CYP3A4 inhibitors, cause therapy, and therefore it has been approved but does have a very strict risk evaluation mitigation strategy around it, where you must be certified to prescribe it after enrolling and completing training, and it can only be dispensed by pharmacists who've also been certified. That being said, I don't think we have to feel like we're missing a huge amount. There was a recent systematic review and meta-analysis published in JAMA Internal Medicine where they put together the results of 5 published and 3 unpublished studies that included both premenopausal and postmenopausal women. In total, almost 6,000 women, though their final judgment of these studies was that together they offer very low quality evidence due to high dropout rates, which raise risk or concerns of within study bias. But this is a way of saying it's not that it wasn't approved because it wasn't studied. It was studied, and it's probably not safe. When they looked more specifically at the premenopausal women, they found that treatment with flubanserin resulted in 1/2 additional satisfying sexual event per month. So grand scheme, some benefit, but arguably not a clinically relevant benefit to many patients. And that comes at the cost of statistically and clinically significant increased risk of nausea, dizziness, somnolence, and fatigue. So new medication that's out there, but I have to admit I haven't been trying to find time in my own schedule to get trained to provide that. Not a good option for our postmenopausal women with hypoactive sexual desire, and I'm not totally clear that it's actually a great option even for our premenopausal patients. So how can we help our patients who are struggling with hypoactive sexual desire? Couples counseling is probably the most tried and true way to help such couples. Lubricant is also really important, and lubricants vary and they're not all the same, and if people have tried water-based, they haven't tried silicone, trying both of those. All applied to the vaginal mucosa or used transdermally can also be helpful. Risks of cardiovascular disease or deep venous thrombosis are acceptable to the woman in the context of the symptoms she's experiencing. Moving to our, there we go. The other thing that often becomes an issue at this intersection between women with perimenopausal or postmenopausal experiences has to do with urinary incontinence and infections. And just to be clear, we have both stress incontinence, and the symptoms there can be somewhat different during at least intra. Well as with urge incontinence, the leakage is more frequently associated with a sense of urgency. And causes are thought to differ, as we might also expect, where stress incontinence is most frequently due to weak sphincter or muscles, but it can also be caused by hyperglycemia, which is an osmotic diuretic, and so it pulls fluid out of women's bodies and gives them that much more urine to try to process. And similarly, urge incontinence, which is thought to be sort of hyperactive bladder, the contractions of the detrusal muscle happen more frequently than might be expected, again, can be exacerbated by poor sugar control. So I guess the takeaway here would be if you have a patient complaining about urinary incontinence or frequent urinary infections, important to remember to think back to looking for whether there's sugar in that urine or whether anybody's looked at how it is controlled. We like to see that go below 7. So if we have challenges in the sugar department addressed by hypoglycemic medications, but if that's not the primary behavioral therapy for the stress and Kegel exercise, physical therapies, along with those medications for glucose control. And for urge incontinence, things like caffeine reduction, trying to make sure there's been bladder retraining with timed voiding and perhaps decreasing the amounts of fluid intake. There are also other therapies that are sometimes used for stress incontinence, pessaries or surgery, and for urge incontinence, some of the anticholinergic medications. And then again, if the symptoms seem to be due to atrophy of the vaginal mucosa, sometimes vaginal estrogen therapy can improve these urinary symptoms and decrease irritation with voiding. And vaginal estrogen therapy has been shown to reduce risk of recurrent urinary tract infections. So we have another question for you about whether you think that herbal remedies are an option in managing vasomotor. And so you get to choose whether your practice is true or whether that's something that you're not regularly offering. And it looks like we're getting a number of responses back. And this one we seem a little bit more split. We're offering herbal remedies, and their participants think that that is not something that makes sense to offer. So I want to just take a bit more about vasomotor, what we have to offer our patients when they come to us asking for help there. So the first line I guess we should talk about is what are vasomotor symptoms and what do they reflect? And these have to do with differences in the way the vasculature and the skin levels are conveying temperature to the body core. And so they can be very responsive to small differences in temperature change. Sometimes lifestyle changes like cool environments, but even more than that, things that while otherwise, like obtaining a healthy weight, stopping smoking, can also be helpful. Low-dose paroxetine has been labeled by the FDA as a treatment for these vasomotor symptoms, and herbal remedies are, and they do seem to be generally benign, so I don't have a concern about women using them if they would like to, but studies have looked at most of the isoflavin supplements or vitamin E or omega-3 fatty acids. The rigorous studies have found better than a little bit on things that aren't necessarily helping them. That being said, placebo effects can sometimes be very helpful, and if the patient feels like it's giving her help, then I don't have any need to really deprive her of it. They don't worry about it being risky to her. Hormone standard, estrogen being the hormone I mean there, and that is the sort of definitive way to get rid of these symptoms for women, whether given as a systemic estrogen in combination with progestin or with other combined products. If the woman has undergone hysterectomy, she doesn't have the need to worry about endometrial protection while on estrogen, and she can just take the estrogen alone. But if she hasn't undergone hysterectomy, she is going to either need a daily or a cyclic progestin. Option would be to have a progestin-containing IUD like a Mirena or a Liletta or even a IUD put in place. Progestogen products or symptoms, but they alone do not estrogen-containing products for women who are finding these symptoms very distressing. And women can, in fact, find these symptoms very distressing and result in a great deal of sleep loss, which can then end up causing all sorts of other distress during the rest of the day. So those options that are currently recommended as alternatives to estrogen that seem to have some evidence behind them in rigorous trials include cognitive behavioral therapy and hypnosis. Again, paroxetine is the only FDA-approved non-hormonal treatment. There are some other SSRIs and SNRIs and clonidine and gabapentin that have some efficacy in published studies. However, I always worry a little bit about publication bias on that and would note that gabapentin was reviewed by the FDA to be labeled in this capacity and did not win FDA approval. So my first line is the low-dose paroxetine for women who aren't interested in estrogen, and I would think about trying some of the SNRIs or clonidine before going to gabapentin. Weight loss is something that you can recommend with caution as a quick fix for their vasomotor symptoms, but of course recommend enthusiastically for all other aspects of its benefits on their life. Mindfulness-based stress reduction, again, has some evidence behind it. And I should say these recommendations are coming out of the North American Menopause Society, which recently just published a nice review of all of this if you want to take a look and read the entire document in detail. Stellate ganglion block, another option, although in my mind we sort of reserve that generally for people who have very severe symptoms that really are not responsive to any other treatment, since it is a nerve block and it is a permanent approach. Those things, though, that they don't have full recommendation because the evidence doesn't fully support them, are most of the other OTC supplements and herbal remedies, acupuncture, calibration of neural oscillations, or chiropractic manipulations. And in terms of how this is to impact our practice, I think when discussing non-hormonal treatments for menopause, we need to be aware that there's really relatively limited evidence supporting most alternatives to estrogen. So if women are really dreadfully symptomatic and really need a quick resolution of their symptoms now, we need to probably talk about the risks and benefits of an estrogen-containing therapy for them. At the other hand of things, though, although many proposed menopausal treatments may not have been proven to be beneficial for these vasomotor symptoms, some of them are relatively benign, such as cooling techniques, and may have other benefits, such as yoga and exercise. So it's a little hard to ever get into the mindset that that could be a bad thing to be recommending to someone. Try to make sure. So we're going to switch gears now and talk about how to offer contraception to those women with perimenopausal symptoms as well as diabetes. We've talked in the past about the CDC's medical eligibility criteria, which provides some nice guidance around the use of all available contraceptives and the ways to think about those when diabetes is combined with other vascular risks, such as obesity or hypertension, or if the diabetes has resulted in end organ disease or other complications. So that would be vision loss or neuropathy, burning in their feet, or any kidney dysfunction. So we always want to consider the full range of women's current existing medical conditions. Sometimes we also want to be mindful of whether there would be non-contraceptive benefits, and for women who are having heavy menses, perhaps due to fibroids, reduction in those menstrual symptoms can be very important in terms of quality of life as well. Sorry about the slide flipping here. Let's see if we can talk here just for a minute about prevention of sexually transmitted infections. We mentioned this before, but it is worth coming back to, both because as lifestyle patterns change, it's often harder for older couples to convince each other to use condoms than it was when people hadn't gotten used to having sex without condoms. And so this may result in greater susceptibility to STIs. Nonetheless, encouragement for consistent condom use is really at the backbone of most prevention efforts. And I think it's often important to remind couples that there are multiple types of condoms available, and there's not one condom that fits every man or every woman. We have condoms both for men and for women. And sometimes it can be helpful for men to use one of the websites that helps them find their right condom size to pick the condom that they will be most comfortable using. When people find new partners, or if they've been having sex with multiple partners, we generally encourage screening for sexually transmitted infections. And this is a population that may benefit from vaccination against hepatitis B, as sometimes these are patients who are old enough that they didn't get immunized when we started doing hepatitis B vaccines for all. Beyond that, there is a recommendation that anybody with diabetes get the hepatitis B vaccine because of the exposure to blood products that is involved when we ask people to check their sugars using these glucometers. So poking your fingers and working with those different sugar check technology devices puts people at a little bit more risk of getting exposed to different blood products, and especially if they're possibly sharing those tools with other family members, which is not recommended. We want to make sure we've got them fully protected, and hepatitis B is one of those viruses which could be fully prevented using a vaccine, so that's a nice thing. Hepatitis C is the other virus that there's recommendations to screen for, can be sexually transmitted as well as transmitted through blood-borne infection contact. And there are now treatments for hepatitis C as well, which make this a reasonable thing to be offering our patients. So let's shift gears and talk about a case. This is a patient named Felicia. She's 45 years old. She has had 2 pregnancies, which she carried to term. She's had type 2 diabetes for the last 5 years and has no known complications. So it would be reasonable for her to use an estrogen-containing contraceptive if she'd wanted to do so, but there might be reason for some concern with use of estrogen, and on discussing that with her provider, she decided about 9 months ago that she was going to stop taking any exogenous hormones. And since she's done that, her cycles have been irregular. She's having some hot flashes, and she's having some difficulties with left lubrication during sex. The medications she's taking currently include metformin for her sugar control, pravastatin for her cholesterol, lisinopril, which is our favorite, or that family, that ACE inhibitor family, our favorite type of blood pressure medication for people with diabetes because of its beneficial effects on protecting the kidneys. And then aspirin, which again is going to be recommended for anybody who has an increased risk of vascular disease. Her blood pressure is 130/88, and her BMI right now is 31, which makes her in the range of clinically obese, which is anybody with a BMI of greater than 30. So what other things do we want to know about her? Do we want to order any labs? And I would argue we probably do need some lab tests to understand how we're doing in taking care of her. Her hemoglobin A1C is going to be a measure of her sugar control over the last 3 months, and hers comes back at 7.2, which is a very acceptable range. We'd like to see those close to 7, definitely under 8. She has mildly elevated triglycerides, a mildly elevated LDL, but her renal function as measured by her BUN and creatinine remains normal. So what can we do for her in terms of trying to reduce her risk of adverse health outcomes going forward? It starts to become a relatively long list. We need to think first about her diabetes care. For that, she's going to need an annual eye exam, an annual foot exam. She needs to make sure we're doing a good job controlling her blood pressure so we can keep her kidneys healthy for as long as we can. And exercise and a healthy diet are going to be really important in trying to make sure that she keeps her diabetes from progressing and requiring even more medication in the future. At this age of 45, she may still have the possibility of becoming pregnant. She's not ovulating regularly, but she is ovulating now and then. And so depending on what her feelings are on whether a pregnancy would be welcome or would be intolerable, contraception may remain an important part of care we need to provide her. In general, avoiding estrogen, in my mind, is a good idea when we have women who start to have these multiple risk factors of becoming on the older side of over 35 years of age, as well as having diabetes and hypertension and obesity all coming together. But again, if the only option was acceptable to her included estrogen, I would feel comfortable with that. But we have so many better options these days in terms of the subdermal implants and the intrauterine contraceptives, which provide no vascular risk and really are 20 times more effective than our estrogen-containing contraceptives. I like to go with those if they are options that the women themselves find okay. And then we also need to think about how to deal with her menopausal symptoms. For her vasomotor symptoms, which seem to be interrupting her sleep, my first go-to would be a trial of low-dose paroxetine. You can either get the version that they picked to FDA label, which is a funny number of milligrams that makes it hard to split a tablet and get there, or in my mind you can just use the older version of paroxetine at the lowest 10 milligram dose and say might be a little more than is needed but probably won't harm her because we frequently use much higher doses of paroxetine for people who are using it to treat depression or anxiety. If she's struggling with vaginal symptoms, a trial of lubricants or low-dose vaginal estrogen are also things to be thinking about. And we also want to be mindful of her risk of sexually transmitted infections, as well as whether she's having any difficulties controlling her urine. So screening for all of those things is going to be important during our conversation with her. So a question for you, should Felicia continue to use contraception at the age of 45? And I'm curious to hear what this group thinks. Your options are yes, no, it depends, or I'm not sure. And we've got some responses coming in here. And it looks like 2/3 of you guys think the answer is yes. A minority say no, some are unsure, and a good chunk say it depends. And I guess I would say I don't think there's an absolute right answer here, but I think I would put myself in the it depends category. I really think it often depends on how a woman feels a pregnancy would affect her life. There is definitely still a chance she could become pregnant at 45, and I think the bigger question is, would that be something she would welcome, or would that be difficult for her? If it would be something that would be difficult for her, we definitely have contraceptive options that would be safe and effective, and so we need to make sure our patients know they have those options and that they don't come away with the unfortunate sense that too often women with chronic medical conditions get, which is that birth control is not safe for them. And we need to make sure people know that birth control comes in lots of different flavors and lots of different varieties, and there are some that carry more risks and some that carry fewer risks with different chronic conditions. But in essentially all cases, our contraceptive options are going to be safer for a woman than a pregnancy, especially if it's undesired. So let's see if we can get to our next slide here. So in dealing with her and how we're going to talk to her about contraception, important to remind her that there is still a possibility of pregnancy, even though it becomes smaller after the age of 45. And if this was something that she actively wanted instead of just being okay with is definitely something that we would probably want her to get over to see a fertility specialist sooner than later. We really need to ask about her preferences and knowing how to best care for her. But we want to counsel her about contraceptive options using those guidelines put forward by the CDC's medical eligibility criteria, or MEC. And just in case there's anybody on this call who hasn't used those before, the best way to find those is to Google CDC MEC, and you will have one of their tables pop up right in front of you that goes through all sorts of different medical conditions, I think like 160 of them, with each of the available contraceptives and a recommendation about whether it's acceptable or an unnecessary risk. And then we would want to educate her about lifestyle changes and recommend vaginal lubrication if that's bothering her when she's trying to have sex. So in summary, a reminder that estrogen-containing contraceptives, which include the pills, patch, and ring, though we do have a progestin-only pill, most of the pills do contain estrogen, are considered CDC MEC category 3 or 4, meaning they're generally not to be used with women who have multiple cardiovascular risk factors, and those are commonly thought to include diabetes, hypertension, and obesity, but I would add people who are having a lot of vasomotor symptoms to that list as well, as both menopausal symptoms and diabetes increase women's risk of cardiovascular disease. And so we need to be mindful of taking advantage of therapies that can reduce those risks of cardiovascular disease, such as baby aspirin once a day and a statin if the woman can tolerate those. We also need to remember that menopausal women with diabetes often end up with genitourinary symptoms in addition to vasomotor symptoms, and it's sometimes hard for women to bring those to our attention. So we need to provide prompt questions that allow women to share with us any concerns that they may have about the way their body has been changing as they go through this perimenopausal transition, and whether there's any symptoms that they are finding distressing. So with that, I will say thank you for your attention, and we're going to shift gears and go on over to any questions that you may have, and I will see what we have pulled up here if I can. And I should say, Caitlin, if you have a better view of questions that have come in, I know I saw some come in, but now I am having a hard time seeing them again. I apologize about that.
No problem. 1 second. Okay, so we do have a question. Baby aspirin for women aged 45 and above is a rule for all or only for the symptomatically perimenopausal women with diabetes?
So the U.S. Preventative Services Task Force has put forth guidelines related to aspirin, and they put those out there for all women. And men, I should say. So for men, they start everybody at age 45, and for women, they say all women starting at age 55. But in my mind, we need to think about stretching that a little bit further for women who we have other reason to think about maybe at increased risk of heart attack or strokes. And so women who we know have diabetes, women we know have hypertension, women we know have other conditions that may increase their risk of vascular disease, like autoimmune diseases like lupus or like renal insufficiency. All of those folks who we have to worry about what's going on with their vasculature and whether it's been damaged, and think of them at high risk. In my mind, once we start thinking about them as high risk and trying to do things to reduce their risk of heart disease and of stroke, that's the time to start a baby aspirin. As I tell many of my patients, if you're having chest pain and you go into the emergency room, the very first question that they are going to ask you is, did you take an aspirin today? And if you didn't, the first thing they're going to try to get you to do is swallow an aspirin. So you're just going to be that much ahead of the curve if you've taken a baby aspirin that day. Now, that's not to say that people who are unable to tolerate aspirin because it's giving them stomach upset need to, just grit their teeth and take the aspirin anyways. But for people who find that the baby aspirin doesn't cause them any symptoms, when I say baby, I mean 81 milligrams of aspirin, it's a good thing to go ahead and start. And so again, the U.S. Preventative Services Task Force recommendation is starting at age 55, but in my mind, if we have women who are terribly symptomatic with vasomotor symptoms, which we know is a risk factor for going on to have cardiovascular disease, in my mind, the time to start that relatively benign treatment is whenever they start telling us about those symptoms.
Great, thank you. So we have another question. Should HRT be used with caution for a diabetic menopausal female?
And I want to say clearly, yes. Caution with hormone therapy is always warranted. And I want to just also footnote there, we're moving away from calling it hormone replacement therapy because as women age, it's not that they need to be replaced, but that sometimes they have conditions for which we're going to treat with hormone therapy. But these are clearly therapies that do come with some risk, some significant risks of heart disease and stroke and breast cancer increasing. And really this is where we have to engage in shared decision making with our patients and understand how miserable are they from these symptoms. And often I encounter women who are so miserable that they are willing to take what is on an absolute level a pretty small risk of adverse outcomes for the symptomatic relief that they need, even if it is an increased relative risk just because they are so miserable. But that would be not at all to override the idea that caution is probably always warranted when using estrogen-based therapies, and extra caution is warranted when using them for women with diabetes.
Great, and I think this is kind of a follow-up to that, but does HRT increase the effect on diabetes?
And so that's a great question, both for our women in the perimenopausal period and the menopausal period, as well as for our younger women. There's sometimes concerns about giving them hormones and whether that will affect their abilities to control sugars. And my understanding of that is that it's minimal, if any. So that is not a reason to sort of decide for or against use of hormonal therapies. The bigger issues are really generally the vascular risk profiles and whether those risks are acceptable to a woman given the symptoms that she is experiencing.
Great, thank you. We have another question from Irma. Which vaginal lubricant do you recommend?
I would say I don't have a favorite, and usually what I do is engage my patients in a conversation around what have they tried, and mostly try to share the same message that I share on a lot of topics, which is that there are other options, and sometimes it's best to try them all, and then once you've tried them all, we can talk about which one worked best for you when, whether that's vaginal lubricants, or whether that's contraceptive options, or even whether that's hormone therapy in the postmenopausal period. There are so many options out there, and it's very hard to predict which is going to be the best one for any given individual.
Great, thank you. Again, we have a couple more minutes, so if anyone has questions, please enter them into the question box. So a couple more minutes.
So I see we have a question about edamame for vasomotor symptoms, or soy intake from dietary sources, and that has been an interest that has been out there. It does seem like there are genetic differences and cultural differences in the way that communities experience menopause, and some communities that tend to eat more edamame and soy, like the Japanese, seem to have fewer vasomotor symptoms. It is not as clear that women can, who are living in the US and have been eating a Western diet for years, end up with the same benefits by trying to eat more edamame. But again, it's one of those things that I think the risk profile is quite benign. I think edamame are nutritionally fine for folks. I just wouldn't be too surprised if we didn't see a change in the symptoms that they were looking for.
Great. Do you see any more questions on your end?
I feel like I'm looking at questions through a tiny little peephole, but the peephole that I have doesn't seem to have any new questions right now.
All right. Well, with that in mind, we'll go on to the summary statement.
I would say I just had one more question pop in, which was a case that it sounded like somebody was sharing. I had a patient who had severe cardiovascular problems but came in for the first visit begging to be restarted on hormones, and she said she basically didn't care if she died. And I would say I have had many such patients, so I appreciate the putting it out there that there are some states that people get into that they feel are worse than death, and I find that there are unfortunately a good number of women out there still who are really just suffering tremendously from their vasomotor symptoms. And as this clinician who wrote in said, I had her sign a form stating she understood the risks and her feelings were as this, and I restarted her on the therapy and she was tremendously happy. And the clinician asked, what would you have done? And I would say I would have done the same thing. And I really think this is again, a reminder that we need to understand what our patients' goals are for their lives and their health and their care and how they balance these different things. And our goal is to provide them with information and education about the risks and benefits of the available medications. But at the end of the day, they have to tell us how those risks and benefits impact their life and whether this is something they want or not. So if we don't have any other questions, we can shift back to this summary slide, which is a reminder that both menopause and diabetes share an increased risk of cardiovascular disease, that we need to remember to address genitourinary and vasomotor symptoms, which we didn't really talk about much in the questions, but are really, really common and really important. And that we have to be careful about using combined oral contraceptives or patches or rings with women who have multiple risk factors for cardiovascular disease, because these are considered MEC class 3 or 4. The other chronic condition that is also a vascular risk factor that we may see in reproductive health clinics a little bit more often and we may not be recognizing as a vascular equivalent is HIV, and that inflammation of that infection seems to have adverse effects on vasculature over time. And even when people have been treated with medications to suppress their viral load, we sometimes see those patients at increased risk of heart disease after they've lived on into the future. So with that, I will turn it back over to Caitlin, and she can tell us about the upcoming webinars that ARHP has to offer.
Great. Thank you so much again for that thoughtful presentation, and thank you all again for joining us today. And I apologize again for the earlier audio issues that we were having. And again, we want to give another special thanks to our presenter for her very informative presentation. So at this time, I just want to direct your attention to the next session, the final session that we have in this series on June 8th, where we'll discuss frequently asked questions about screening, treatment, and counseling. In the follow-up email to this session, you'll receive a link to a survey where you can submit all of your questions. So stay tuned. And if you'd like to check out more of ARHP's educational resources, please visit our website at arhp.org. And now on to the post-test survey. So an hour after the session ends, you will receive an email containing a link to the post-test survey. After completing the form, you'll be able to print out your continuing education certificate. If you have any problems, please email us at education@arhp.org. Thank you again for joining us today, and we hope you will take part in other live sessions hosted by ARHP.